We'll talk about acute severe hypertension in adults and pregnant women. Hypertensive emergency is a clinical syndrome of significantly elevated BP associated with rapidly progressive end organ damage. It is associated with significant morbidity and mortality. Severe hypertension is usually defined as systolic blood pressure more than 180 or diastolic blood pressure more than 110. The key distinction of severe hypertension from a hypertensive emergency is the lack of rapidly evolving end organ damage in severe hypertension. Hypertensive emergencies are more likely to occur in persons aged more than 60 years, in African Americans, in males, in underinsured or uninsured, and those who are living in low socioeconomic areas. We need to understand autoregulation in order to identify the correct patient and also when to treat. In person with normal BP regulation, there is appropriate balance between normal vital organ perfusion, hypoperfusion, and hyperperfusion. It is the rate of change of blood pressure that increases the likelihood of end organ damage. As the degree of BP elevation does not correlate with severity of end organ damage, individuals with long-standing hypertension may have adaptive autoregulatory changes that protect organs from sudden increases in BP. In previously normotensive patients who have acute hypertension, that is, in pregnant women with preeclampsia, hypertensive emergency can occur at lower mean arterial pressures. This picture shows the difference between normotensive patients versus chronic hypertensive patients. In chronic hypertensive patients, it is based on the cerebral blood flow graph. The wider blood pressure can tolerate without having any target organ damage. And when the blood pressure goes up, it can cause diffuse endothelial injury, retinal damage, and cerebral edema. When it falls below the critical point, it can cause cerebral ischemia in case of brain, it can cause acute kidney injury, and also other ischemic events in those particular organs. How does the pathophysiology plays into it? Rise in blood pressure activate renin-angiotensin system, oxidative stress, and endothelial dysfunction that causes protein fragmentation and formation of neoantigens. It activates T cells, and that in turn promote the entry of inflammatory cells and release of cytokines. That causes vasoconstriction and sodium and water retention. And that further accelerate more severe hypertension. I want to go through the differential diagnosis of hypertensive emergencies. One should remember acute severe hypertension can present from hypertensive encephalopathy, posterior reversible encephalopathy syndrome, reversible posterior leukoencephalopathy syndrome. These disorders present as headache, nausea, vomiting, confusion, seizures, and coma. The diagnosis by MRI, sometimes you got to have a CT head, CTA, and MRI brain. Acute ischemic stroke often present with focal neurologic deficit. Again, CT, CTA, and MRI brain. Subarachnoid hemorrhage may have thunderclap headache and meningismus. Again, diagnosis by CT, CTA, and MRI brain, and sometimes they may need lumbar puncture. Intracranial hemorrhage often have stroke-like symptoms, Cushing triad, bradycardia, respiratory depression, irregularity, widened pulse pressure, and fixed dilated pupil. The diagnosis by CT brain. Hypertensive retinopathy present with visual acuity changes, ophthalmoscopic examination is warranted to make the diagnosis. In aortic dissection can present as acute heart failure, acute coronary syndromes, cardiac tamponade, ischemic limb stroke, mesenteric ischemia, and renal failure. The diagnosis by CTA, abdominal and thoracic ultrasound, and angiography. Pregnant women with preeclampsia, eclampsia, and HELP syndrome present with severe headache, visual disturbances, and altered mental status and seizure. Diagnosis by urine analysis, serum creatinine, and platelet count liver function tests. Hypertensive retinopathy may present with vision changes, often asymptomatic. Ophthalmoscopy is necessary for all patients with acute severe hypertension. TTP and HUS present with thrombocytopenia, renal failure, alternate status in case of TTP, and also fever, and HUS can present with renal failure, anemia, and thrombocytopenia. These patients need CBC, complete metabolic panel, PT, PTT, fibrinogen, and LDH. DAC present with coagulopathy and thrombosis. PAN, polyarteritis nodosa, will present with cutaneous lesions, fatigue, weight loss, fever, and arthralgia. CRP SED rate will be high, CTA and angiography will be diagnostic. Takayasu arthritis, aortic regurgitation, claudication, bruits may present in them. CTA, MRI chest, angiography, and SED rate and CRP needs to be done. Those will be higher. Acute renal failure present with oliguria, confusion, pericarditis. Scleroderma renal crisis can present with oliguria and anemia. Urine analysis, basic metabolic panel, renal ultrasound needs to be done in those patients. Acute glomerulonephritis, recent URI or skin infection, urine analysis, BMP, C3, C4 levels, and blood counts needs to be done. Renal artery stenosis often seen in young adolescent girls. Young onset hypertension, abdominal bruit. These patients need duplex renal ultrasound, CTA, and MRI. Myocardial infarction present with chest pain and shortness of breath. Electrocardiogram and troponin needs to be done. Congestive heart failure can present with shortness of breath, lower extremity edema, jugular vein distension, and gallop. Chest X-ray, BNP, and EKG needs to be done in those patients. Sometimes substance abuse medication can cause acute severe hypertension. You can see entirement reaction with monoamine oxidase inhibitor, tyramine-rich diet, sympathomimetic syndrome like diaphoresis, mydriasis, tachycardia, and hyperthermia. Abrupt withdrawal of clonidine, AC inhibitors, or beta blockers can cause acute severe hypertension. Serotonin syndrome can present with altered mental status, hyperthermia, tachycardia, clonus, and hyperreflexia. Sympathomimetic exposure can present with diaphoresis, mydriasis, tachycardia, and hyperthermia. Alcohol and benzodiazepines withdrawal can have acute severe hypertension. Endocrine disorders like Cushing's syndrome, pheochromocytoma, and hypothyroidism can present with acute severe hypertension, but they will have a telltale signs of clinical presentation like hyperpigmentation, hirsutism, amenorrhea, episodic hypertension, tachycardia, and flush skin, exophthalmos, goiter, and hyperreflexia. They need to have an appropriate lab studies to confirm the diagnosis. Sometimes burns and pain can cause acute severe hypertension, and they will be very evident on clinical diagnosis. So, what do you need to do before bringing the patient to the hospital? When compared to acute coronary syndromes and stroke, very few things they need to do in the field. Full set of vital signs should be recorded. IV access needs to be obtained. and last known well time needs to be noted, especially if they suspect stroke. During evaluation, regardless of the BP measurement, emphasis should remain on determining whether end organ damage is present or imminent. It's very important. That makes all the difference where to admit them and what kind of medications needs to be done. Prior hypertensive history. History of the over-the-counter medications, especially cough and cold medications. Substance abuse, cocaine, methamphetamine, or other sympathomimetics. Medication history, especially monoamine oxidase inhibitors, serotonergic medication. Social history such as sodium intake, general diet, alcohol consumption, and GABA agonists. Physical examination, the BP needs to be measured with appropriately sized curve on both arms. The MAP is often preferred measurement of BP for several reasons. Number one being automated oscillometric BP curves measure MAP directly. Second is systemic autoregulation adapts to changes in MAP. So hypertension emergency appears to be more closely related to MAP rather than systolic blood pressure. Titration of antihypertensive medication usually based on a single variable, and by using MAP, there is a less variability compared to systolic and diastolic readings. Because of these reasons, MAP is the better parameter to follow during treatment. What are the common symptoms and sequelae of hypertensive emergencies? The most common presenting symptoms of hypertensive emergencies are shortness of breath. One third of the patients will have shortness of breath. 26% will have chest pain. 23% will have headache. 20% as altered or present with altered mental status. 11% will have focal neurologic deficit. So what are the common sequelae of hypertension-induced organ damage? Hypertension can cause pulmonary edema and heart failure that is present in 32% of the patients. 29% will have ischemic stroke. 18% will have acute coronary syndromes. 11% hemorrhagic stroke. 2% acute aortic syndrome such as aortic dissection. 2% hypertensive encephalopathy. When there is a new onset of cardiac murmur, consider papillary muscle rupture during an acute myocardial infarction or type A aortic dissection. Abdominal bruit and mass indicates renal artery stenosis or aortic aneurysm. Neurologic examination should focus on mental state changes such as delirium, depression level of consciousness, and lateralizing signs. Ophthalmoscopic examination needs to be done in all patients with acute severe hypertension. Grade 3 or 4 hypertensive retinopathy is a sign of microvascular dysfunction and impaired cerebral autoregulation. Retinopathy of grade 3 and 4 will have bilateral cotton wool spots, flame-shaped hemorrhages, and or papilledema. This picture shows flame-shaped hemorrhages, cotton wool spots, and papilledema, consistent with grade 3, 4 retinopathy. This BARC algorithm is easier tool to use whether the acute severe hypertension has associated target organ damage or end organ damage. The BARC stands for brain, arteries, retina, kidney, and heart. The brain, one should look for stroke or hypertensive encephalopathy. In arteries, one should look for acute aortic syndromes or preeclampsia, eclampsia, and HELP. Retina, look for grade 3 and 4 retinal changes. In kidney, acute renal insufficiency or thrombotic microangiopathy. In heart, look for acute heart failure and pulmonary edema. When it is present, means the patient has hypertensive emergency, rapid BP reduction with IV drugs chosen according to BARC. We are going to discuss what needs to be done in different conditions. What are the diagnostic studies needs to be done in patients with acute severe hypertension, especially when the BP is more than 180 over 110? They are grouped into two categories: with symptoms, without symptoms. With symptoms, admitted and diagnostic studies needs to be done in the hospital. If the patient do not have any symptoms but the blood pressure is so high, routine diagnostic studies are not needed immediately. Asymptomatic hypertension can have adverse cardiovascular events if they have other risk factors such as age, sex, diabetes, atrial fibrillation, or prior cardiovascular disease or consequence of chronic hypertension. They would not benefit from aggressive antihypertensive therapy or further inpatient evaluation. What are the basic lab analysis one need to do? Assess the renal function, electrolyte balance, red blood cell parameters, urinary analysis and microscopy, complete blood count, glucose, troponin I, and in case of women, pregnancy test. If there is a suspicion of myocardial infarction or dysrhythmia, meaning present with chest pain, palpitations, shortness of breath, electrocardiogram needs to be done. Left ventricular hypertrophy with long-standing hypertension increases the risk of cardiovascular disease and early death. Some patients can present with left heart strain pattern on EKG, meaning ST depression with the downsloping convex ST segment and discordant T-wave inversions in the lateral precordial leads. Higher prevalence of concentric hypertrophy, lower myocardial contractility, and higher myocardial oxygen demand have been seen in patients with left heart strain on EKG. The EKG, when you do, it will show downward sloping of the ST segment along with T wave inversions. Other imaging studies needed are chest radiography. It might show interstitial pulmonary edema or cardiomegaly. POCUS. Most of the centers are started using POCUS, which is point of care ultrasound. It may identify aortic dissection, evidence of left ventricular hypertrophy, diminished ejection fraction, pulmonary edema, and other causes of bladder outlet obstruction. CT heads needs to be done to rule out ICH, cerebrovascular ischemia, and hypertensive encephalopathy. MRI of the brain, especially T2-weighted FLAIR MRI, can identify hemorrhages and, most importantly, posterior reversible encephalopathy syndrome. Non-contrast head CT is the gold standard for diagnosing subarachnoid hemorrhage. CT angiography of the brain look for intracranial aneurysms that can cause subarachnoid hemorrhage. This slide shows hemorrhage in different sites, different areas of the brain. The first one shows brain hemorrhage in putamen, brain hemorrhage in thalamus, brain hemorrhage in subcortical area, hemorrhage in pons, brain hemorrhage in cerebellum, and in temporal lobe. So brain hemorrhage can happen in any part of the brain. The classic findings with posterior reversible encephalopathy syndromes will be seen in CT and MRI. Papal edema is a surrogate marker for cerebral edema, can be evaluated using ultrasound to measure optic nerve sheath diameter. Optic nerve sheath diameter more than 5 millimeter has been shown to be 95% sensitive for papal edema. It's a feasible tool to assess for intracranial pressure. This is the MRI, shows the signs of posterior reversible encephalopathy syndrome. This is a POCUS, point of care ultrasound in the eye. It's a great tool to make the diagnosis of papal edema. That indirectly means cerebral autoregulation is not working anymore or increased intracranial pressure. want to walk you through one by one. The anterior aspect, as you can see, cornea, next to it, iris, then lens, then the big black space reflect, meaning vitreous body. And the posterior aspect is retina. Just posterior, 3 millimeter posterior to that is optic nerve sheath. If the optic nerve sheath is more than 5 millimeter, is indicative of papilledema, a sign of elevated intracranial pressure. Next is treatment. The treatment, we are going to talk about different disease states. Every different disease states have a different BP targets and different form of treatments they need. In acute decompensated heart failure, focused on both on lowering the patient's systolic blood pressure as well as improving respiratory distress. There are three interventions commonly employed. One, non-invasive positive pressure ventilation. Number two, diuretics. Number three, vasodilators. Second is diuretics. There is a conflicting evidence about the utility of early IV diuretic use in acute decompensated heart failure. Early administration of IV diuretics reduces in-hospital mortality in acute decompensated heart failure. 2021 ESC, 2022 AHA guidelines recommend using loop diuretics for those with signs of volume overload. What kind of IV dose do you use? 1 to 2 times the patient's equivalent maintenance dose with close monitoring of urinary output. Vasodilators. Multiple randomized control trials have demonstrated that vasodilators are safe and effective in lowering systolic blood pressure in acute decompensated heart failure. No improvement in short or long-term survival. AHA guidelines says role of nitroglycerin and nitroprusside is uncertain and recommend their use only as an adjuvant to decrease the preload for relief of dyspnea in hypertensive patients. The dose used for nitroglycerin is 600 microgram to 4 milligram over several minutes, followed by 50 to 100 mics per minute. Clavidipine is effective in quickly reducing systemic blood pressure, systolic blood pressure in patients with hypertensive acute decompensated heart failure. Nicardipine, more available and cost-effective option. It is most commonly used in the United States. Urapidil is not available in the United States, but it's available in Europe. Sympatholytic vasodilators that might improve short-term cardiac function when given in emergency department. Two important things. Morphine should not be used in the management of patients with acute decompensated heart failure because it has been shown it increases mortality 5-fold. Nesiritide should also not be used to manage acute decompensated heart failure because there is no clinical benefit. So what are the blood pressure targets in acute decompensated heart failure? ESC and AHA guidelines do not mention any specific target. But the post-hoc analysis of reality AHF study reported patients the blood pressure that was reduced more than 25% of systolic blood pressure may have had a higher mortality rate. So it's reasonable to target lowering systolic blood pressure by 10 to 25%. Do not overdo it. Then have a target blood pressure and reduce to that level. The next disease condition is acute ischemic stroke. Non-contrast CT scan needs to be done to exclude ICH. For patients receiving thrombolytics and mechanical thrombectomy, the guidelines recommend lowering blood pressure less than 185 over 110 prior to the intervention. Then maintain less than 180 over 105 for 24 hours post-intervention. ESO do not mention any specific antihypertensive. On the other hand, AHA recommend nicardipine, clavidipine, or labetalol. If the BP is more than 220 over 120, both the guidelines state lowering BP no more than 15% is reasonable. So you have to be very specific in bringing down the blood pressure and be cautious. Lowering a systolic blood pressure more than 15% is significantly associated with those outcomes, especially in those aged more than 70 years. Acute coronary syndromes. What are the BP targets? Acute coronary syndrome includes STEMI, non-STEMI, and unstable angina. During the acute stages of acute coronary syndrome, meaning within the first 24 hours or prior to the definite treatment with thrombolysis or percutaneous coronary intervention, no data to suggest an optimal blood pressure. But we know systolic blood pressure less than 100 on admission is a strong predictor of increased mortality within 6 months. And also, those who are hypertensive at presentation have good outcomes. So in acute coronary syndromes, it treats them very differently than other disease states. Blood pressure frequently fluctuates in the early stage of acute coronary syndrome, so management should be focused first on pain control and clinical stabilization. Usage of beta blockers in acute coronary syndrome. Hypertension patients with STEMI, beta blockers with high beta 1 affinity should be used. The reason being, it reduces the recurrent myocardial infarction, ventricular fibrillation, and decreased infarction size. The same token, when the systolic blood pressure is less than 120, age more than 70 years, and the heart rate is more than 110 beats, when you give IV beta blockers, there is a high risk of developing cardiogenic shock. So we need to exclude certain population before we embark upon giving beta blockers. That brings to what are the contraindications for beta blockers? As you mentioned earlier, systolic blood pressure less than 120, age more than 70, heart rate more than 110. ESC guidelines suggest, in addition, acute decompensated heart failure, hemodynamic instability, and high degree of atrioventricular block, they should not be given beta blockers either. Beta blockers can be used to treat hypertension in patients with acute coronary syndrome, but it's recommended to lower the BP slowly to avoid diastolic blood pressure less than 60 to maintain coronary perfusions. So you have to use it with caution, even though beta blockers have beneficial effects. Other category is nitrates in acute coronary syndrome. The both guidelines recommend IV nitrates for hypertensive patients with non-STEMI, but these guidelines are 20 years old. The recent systemic review shows there is a mortality benefit in the first 24 hours, but there is no mortality benefit in 10 or 30 days. But in practice, nitrate should be given routinely to patients with acute coronary syndromes. Next disease state is intracerebral hemorrhage. What are those BP targets? AHA and ESO recommend immediately lower the systolic blood pressure to less than 140 when ICH is recognized, and maintain between 130 and 150, but not less than 130, because it can cause hematoma expansion. Lowering systolic blood pressure less than 180 clearly improves the patient outcomes. It reaches the peak benefit when lowered less than 140. However, reduction more than 60 millimeter mercury worsen the outcome. So be careful, even though lower blood pressure helps, not too much. And also, one should avoid iatrogenic hypertension. That is the highest risk factor for mortality. Its greatest risk happens in the first 6 hours. So what are the antihypertensive medications recommended? The recommended medications should have a fast time of onset and short half-life to prevent excessive BP lowering. The first line medications one should use are nicardipine and labetalol. Next disease state is subarachnoid hemorrhage. There are two kinds. One, associated with aneurysm. Second, not associated with aneurysm, called non-aneurysmal subarachnoid hemorrhage. There is no data to get treatment. In aneurysmal subarachnoid hemorrhage, the primary aim is to prevent the rebleeding within the first 12 hours. So focus is primarily on the prevention of rebleeding within the first 12 hours. Elevated BP increases the risk of rebleeding. So, according to AHA guidelines, lower the systolic blood pressure less than 160 millimeter of mercury. ESO says less than 180. Neurocritical care says only you attend or lower the blood pressure when the MAP is more than 110. I will go with AHA guidelines. Next is aortic dissection. 2022 AHA guidelines recommend reduce the heart rate to 60 to 80, lowering systolic blood pressure less than 120. Very specific. It recommends using IV beta blockers because it can lower the heart rate and systolic blood pressure. It's reasonable to use fast acting. Usually, the recommended or more usable beta blocker in this particular scenario is esmolol. It controls heart rate and controls blood pressure. ESC guidelines recommend lower the patient heart rate and systolic blood pressure. It says give the parameter less than 120 for systolic blood pressure, but there is no mention about the heart rate. We already talked about AHA guidelines. If the patient has a contraindication to beta blockers, one can use calcium channel blockers. The vasodilators recommended by AHA guidelines are nicardipine, clavidipine, and nitroprusside. Hypertensive encephalopathy. It's most commonly seen when the BP is more than 220 over 120. International Society of Hypertension recommend reduce MAP by 20% to 25% using nicardipine or labetalol as first-line agents. PRES is a form of encephalopathy diagnosed on CT and MRI. But one should remember, having PRES in the CT and MRI not necessarily mean the patient has hypertension. They can be hypotensive or normotensive. So make sure PRES with increased blood pressure. Severe preeclampsia, eclampsia, BP targets. ESC guidelines says BP reading more than 170 over 110 at hospital admission. I'll go with ACOG, which is much more elaborate, and the treatment is going to be based on ACOG recommendations, American College of Obstetrics and Gynecology. Hospital admission for women after 20 weeks of gestation who have preeclampsia with severe features, meaning systolic blood pressure more than 160, diastolic more than 110, confirmed by a repeat BP 15 minutes later, or two BP readings more than 140 over 90 and less than 160, 110, 4 hours apart. These patients, especially eclampsia or HELP, associated with thrombocytopenia, impaired liver function, renal insufficiency, pulmonary edema, new onset headache, unresponsive to medication, or visual disturbances. ACOG recommends reduce the blood pressure quickly. To what target? Less than 140 over 90. It has been shown when you lower the blood pressure quickly, less than 140 over 90, lower the rates of preeclampsia, eclampsia, and preterm delivery. ACOG recommends following medications to achieve those targets. What are those? IV labetalol, IV hydralazine, or oral immediate release nifedipine. The hypertension is associated with maternal hypertension, placental abruption, adverse effects on fetal heart rate, cesarean delivery, maternal oliguria, stillbirth, and low Apgar score at 1 minute. IV nicardipine should be considered for treatment-resistant hypertension after using hydralazine, labetalol, or immediate release nifedipine. Preeclampsia with severe features or those with eclampsia Should be treated with IV MAG, loading dose of 4 to 6 gram IV over 20 to 30 minutes, followed by 1 to 2 gram per hour. ACOG acknowledged therapeutic range of 4.8 to 9.6 to prevent eclampsia. It remains in question. But whenever you give IV MAG, one should monitor deep tender reflexes, respiratory rate, and urine output. High magnesium level can cause muscular weakness and decreased respiratory rate, and magnesium is eliminated via kidneys. Next is acute renal failure. International Society of Hypertension recommends nicardipine or labetalol as first-line therapy for acute renal failure associated with severe hypertension. AHA recommends nicardipine, clavadipine, and phenyldipine in patients with acute renal failure, but the Kidney International says there is no utility for phenyldipine to manage acute kidney injury with acute severe hypertension, so that goes through the window. So we left with nicardipine or clavadipine. What is the BP target? Reduce the MAP with a maximum of 25%. The next question is when to give oral, when to give intravenous antihypertensives. IV antihypertensive should be given only if the clinician believes the patient's symptoms and end organ damage is secondary to acute rise in patient's blood pressure and needs to be rapidly corrected. We already given algorithm how to identify the end organ or target organ damage. In the absence of end organ damage or target organ damage, close outpatient follow-up with gradual move toward oral antihypertensive medications need to be done. According to ASAP guidelines, American College of Emergency Physicians 2013, they discourages initiation of BP medication in the ED for asymptomatic patients with hypertension. But I want to bring to the point, it was 12 years old. But clinician can consider initiating BP medication for those who are at high risk, such as African American, elderly, uninsured, or likely to be last to follow up. So those are different category you need to take care of. So this is an algorithm to follow when the patient presents with acute severe hypertension. When the blood pressure is more than 180 over 110 to 120, it should be reproducible on multiple measurements with an accurate device. Then look for acute target organ damage like stroke, intracerebral hemorrhage, press, hemorrhages, exudates, and papilledema in ophthalmoscopy or focus, acute coronary syndromes, and acute decompensated heart failure with appropriate diagnostics, aortic dissection, acute kidney injury, microangiopathic hemolytic anemia. This all needs to be immediately screened. If it is present, admit to intensive care unit, start IV treatment immediately. Select the drug according to the indications which we discussed in the previous slides. Lower the blood pressure according to the pattern of organ injury. There is no universality, so based on the end organ damage, one should choose the right medication and the right BP targets. Start or resume long-acting medication during the first 6 to 12 hours of treatment to reach the target by 48 hours. But if none of those are present, confirm persistent elevation after 20 to 30 minutes of quiet rest. If the symptoms attributable to high blood pressure, give rapid oral agent with just the long-acting medications. Discharge when symptoms have improved and blood pressure is less than 180 over 110. Follow up in 1 to 7 days. The symptoms are not attributable to high blood pressure. It could be from something else. In those patients, adjust the long-acting medication, follow up in 1 to 7 days. Well, if the patient has underlying target organ damage, the patient is already in ICU. Based on the underlying target organ damage, if it is acute coronary syndromes, it is just a recap. Intravenous, sublingual, and topical nitroglycerin, IV metoprolol, There are no risk factors such as age more than 70, heart rate more than 110, systolic blood pressure less than 120 to achieve no more than 25% MAP reduction within the first hour. In acute heart failure, non-invasive positive pressure ventilation, short-term high-dose nitroglycerin titrate down after symptom relief. BP reduction no greater than 25% within the first hour. These patients may benefit from IV diuretics 2 to 3 times of the maintenance dose. Acute renal failure reduce the MAP by the maximum of 25%. Appropriate first-line agents or nicardipine, clavidipine, or labetalol. Aortic dissection, esmolol for goal of decreasing the heart rate and decreasing the systolic blood pressure. Consider addition of nicardipine if the blood pressure cannot be achieved with esmolol alone. Patient with severe preeclampsia, eclampsia or HELP, max sulfate 4 to 6 gram IV over 20 to 30 minutes followed by maintenance 1 to 2 gram per hour. BP should be decreased less than 160 over 110 according to ACOG less than 140 over 90 with IV labetalol hydrolysine. Hypertensive encephalopathy reduced MAP by 20 to 25% using IV nicardipine or labetalol as first-line agent. Intracerebral hemorrhage lowered the blood pressure less than 140 using IV nicardipine or labetalol. Acute ischemic stroke, if receiving thrombolytics or mechanical thrombectomy, lower to the goal of less than 185 over 110 prior to the intervention and to maintain BP less than 180 over 105. If no intervention, the BP is more than 220 over 120, consider lower by no more than 15% in patient with acute ischemic stroke. Next session is controversies and cutting edge. The current indication for arterial lines are when there is a lab-based blood pressure, concern for inadequate or inaccurate automated oscillometric blood pressure cuff readings, clinical deterioration despite non-invasive management. In these three conditions, you do an arterial line. If the patient goes to ICU, we automatically place hotlines. Hotline is probably unnecessary in most cases because the following reasons. Number one, pain of arterial line rises, exacerbate hypertension. There is no prospective evidence to show this procedure is beneficial or necessary. Current BP targets are mostly arbitrary and poorly defined, with the exception of ICH and acute ischemic stroke. In spite of all these criticism, I would put, especially in hypertensive emergency, place an IV because that will help you to bring down the blood pressure appropriately. Beta blockers in cocaine-induced hypertension. Use of beta blockers in patients with cocaine-induced severe hypertension is controversial. The reason being it causes unopposed alpha stimulation in cocaine toxicity. Even though it is theoretical, this phenomenon is inconsistent, unpredictable, and a rare phenomenon, but you have to keep in mind that could happen. Finally, disposition. All patients diagnosed with hypertension emergency require hospital admission. AHA recommends admitting adults with hypertension emergency to an ICU for continuous monitoring of blood pressure and also for parenteral administration of antihypertensive agents. In the emergency department, no hypertensive emergency safely can be discharged with close outpatient follow-up for repeat BP monitoring and consideration of medications as we discussed in the previous slides. In summary, hypertensive emergency is associated with substantial morbidity and in-hospital mortality. It requires immediate treatment. Very important. It is associated with lots of cardiovascular morbidity and mortality. Patient with severely elevated BP, meaning more than 180 systolic, more than 110 diastolic, or MAP of more than 135 should be assessed for end organ damage. Hypertensive emergencies need to be treated with careful titration of antihypertensive. Very crucial. When there is no hypertensive emergency, safely discharged with primary care follow-up. This concludes the seminar on acute severe hypertension in adults and pregnant women. We have already done hypertension emergencies um, in pediatrics, please see in our YouTube channel, that is American Medicine. Thank you so much for listening, and please share with everyone, all the practitioners. Thank you so much again.